Hello friends, very good evening again for this Jaipur surgical tutorial, fifth masterclass. The theme is on surgical critical care. We had excellent four sessions yesterday, and we got immense response from the audience, also on YouTube. We had initial assessment and advanced assessment part yesterday. Now we will see that how we are going to manage in surgical ICUs. The core concept basically these will be going to sensitizing topics to you people because these are very lengthy topics in all. In a nutshell, I'll say. Let's see how it goes. I'll introduce our session chair, Dr. Nikhil Ajmera sir. Dr. Nikhil Ajmera sir is head of the department critical care medicine at Santokba Durlabji Memorial Hospital in Jaipur, and sir is a prolific speaker himself. But we have handed over the responsibility of session chair this time. Sir is a very learned person, an avid learner himself, and a very good teacher also. So I wish a very successful evening this day. Sir, please, I hand it over to you to introduce our speakers and the sessions further on.
Many thanks, Dr. Ravi and the team Jaipur Surgical Tutorial. I think it's a wonderful concept and we are doing great. Yesterday's sessions were also great, and now I hope and I wish all the participants and the speakers the best wishes for the successful completion of this tutorial. Good evening all. Today's evening we are starting with the session by Dr. Pramod Sarva, and he is a consultant critical care medicine, Eternal Heart Center and Research Institute, Jaipur, and he is practicing critical care medicine since more than 10 years. He is a passionate learner and excellent on-site physician, and his core area of interest are critical care ultrasound, ECMO, pain management, and intensive care quality improvement. And he's a part of institutional committee also for clinical and quality improvement in ESCC, and he has got many original publications and book chapters to his credit. The achievements in awards, he has got the Indian West Zone Conference of Anesthesia Gold Medal, and for Dr. Shobna Medar, Memorial Gold Medal also. So the topic of Dr. Sarva is the management of sepsis, the surgical site infection, and skin and soft tissue infection in surgical ICU. So handed over to Dr. Pramod Sarva.
Thank you, Nikhil sir, for the kind introduction. Let me share my screen. Is it visible?
Yeah.
Okay. So good evening, everyone, and thank you, Nikhil sir. And I think I'm very glad to be part of this initiative. And thanks Dr. V.K. Kapoor, Dr. Ravi, and Dr. Anand for adding me in the part of this initiative. So my agenda over next 20 minutes is to explore about surgical site infection, how we can prevent it, how to identify sepsis, and how we can deal with sepsis. So any infection in the surgical wound that occurs within the 30 days after the surgery. And mind you, if the implant is involved, the duration goes up to 1 year. It includes the skin, subcutaneous tissue, deep facial layers, and deep-seated organs, or you have purulent discharge or an organism is identified from the surgical site. It is surgical site infection. Depending on the site, it can be superficial incisional site, deep incisional SSI, or organ space SSI. So why every surgical procedure carries certain risk of getting infected, and depending on the surgical procedures, we can divide into that surgery into the 4 part upon the risk of getting infected. It may be a clean surgery like simple lipoma or ganglion excision when you are just incising uninfected skin without opening a viscous. The chance of getting infected are less. When it is clean and contaminated, like you are opening a viscous deliberately, like in cholecystectomy, the chance of getting infection is more. When a clean surgery has a major surgical breach, it also counts as a clean contaminated surgery. Then comes contaminated and dirty surgery when there is obvious spillage of the colonic content or there is obvious and pus, feces, or exogenous contamination tissue, like in surgical and trauma patient. And the chance of infections are 20 to 25% in contaminated and dirty, 25 up to repeated up to the 40% of the patient. And that's why it creates the huge burden. And this data from CDC in 2018 shows that for the patient, it extend the hospitalization, and for the system, it increase the healthcare cost. And that's why WHO has proposed certain range of precaution before, during, and after surgery to reduce the surgical site getting infected. So we'll dig little deep into it. We ensure patients bath before surgery to remove any particulate matter, any contaminant matter, because most of the surgical infection are endogenous flora. So it removes the particulate matter on which these bugs are adhered to. Regarding shaving, WHO recommended avoid shaving, avoid razors for the skin preparation because it create microabrasion. But if the surgeon is very peculiar about hairs not getting in the OT field, then hair removal should be done in OT with the use of hair clippers. We'll see the antibiotics in the next slides. Chlorhexidine surgical scrub and OT etiquettes are, as the surgeon is the population audience is surgeons, they know the best. And after surgery, you should continue check wounds for the infection, use standard dressing protocol on the primary wound. These are the same things I stated in previous slide. There are preoperative precaution, there are perioperative precaution, and the prophylactic antibiotic therapy to prevent surgical site infection. Now, these 3 points I would like to stress on perioperative management, in which the anesthetic team helps surgeons to get their patient better. It is avoidance of hypoxia and avoidance of hyperglycemia, because obvious reason there are more chance if the patient is hypoxic. Now, your OT is clean in the cold environment, but your patient fight better when he is warm. Because of hypothermia, patient develops coagulopathy, patient develops vasoconstriction, and patient's leukocyte functions gets deteriorated. So it is okay to invest in bear huggers, in body warmers in perioperative period for the patient while you are keeping your OT in a cold environment. Now, for antibiotic, the prophylaxis is indicated only for clean contaminated and dirty surgery. It is not indicated for the elective clean surgery. Now, your choice of antibiotic will depend according to the local practice pattern, local hospital antibiogram, and the timing of your antibiotic will depend on the pharmacokinetic property of that antibiotic. You can repeat the antibiotic dose if your surgery gets prolonged more than 4 hours, and we do not routinely continue prophylactic antibiotic after 24 hours. And by any chance, if you are inclined to continue antibiotic, it's become a therapeutic antibiotic. So, despite all these precautions, certain surgical patient catch infection, and the reason is multifactorial. So there are patient factor and some local factor like open surgery compared to lay, poor skin prep, contamination, inadequate antibiotic prophylaxis, prolonged surgery, tissue necrosis. But there are certain patient factor, we can work upon them, and we can reduce the SSI risk in those patients. So if any, suppose any obese patient, any coming from incisional elective incisional hernia surgery. So if that hernia was remaining for the years, they can wait for 2 or 3 months more, and they can reduce some weight. Old age, as usual, non-modifiable. immunosuppressions. Most of the patient who are post-transplant case, or they are a rheumatoid case, or some steroid for bronchial asthma, we can check with their follow-up physician and we can optimize the immunosuppressive doses. Now, for diabetic mellitus and malnutrition, obviously we can do optimization. We can ask the patient to stop smoking. We can optimize the renal failure drugs. We can correct the anemia. So there are some factors we can work upon and will reduce the risk factor. Obviously, they are expected bugs for the particular surgery. So, like if an orthopedic surgery is there, the most likely these are the skin common cells, Staph aureus, Coagulase negative, staphylococci. For appendixectomy, GNB comes in picture, anaerobes comes in picture. For colorectal surgery, gram-negative bacilli and anaerobes. So always you can pause the video and see the table. And despite all precautions, there are some factors which leads to the development of surgical site infection. So if we dig deep into the microbiology, this is the usual distribution of the share of the etiological pathogens in a SSI. Now, there may be a geographic variation, and this distribution pattern can follow the normal variance. So, after surgery, in the post-op ward, you should continue your wound assessment to see that if this surgical wound is normally healing or it is having some sign of inflammation or are getting infected. This is the more complex sepsis wound score. It takes into the account of the wound characteristic and how much proportion of the wound is infected, or how much proportion of the wound is showing some pattern. So asepsis stands the mnemonics for additional treatment required for that wound, like addition of any antibiotics, additional drainage was done by the surgeon, debridement of wound required, any serous discharge, E stand for erythema, purulent exudate, separation of the deep tissue, isolation of bacteria from the skin swab, and due to improper wound healing, the patient's stay is prolonged more than 14 days. So you calculate the scores and you decide that patient's surgical wound is healing, or it is disturbed, it is minor wound healing, it is moderate wound infection, or it is severe wound infection. So any surgical wound getting infected will generate a host response, and usually it will be an immune response to fight with that pathogen. Now, if that immune response gets dysregulated, the patient becomes septic. So the sepsis is nothing but the life-threatening organ dysfunction caused by dysregulated host response to an infection. When it is associated with circulatory or metabolic dysfunction, it is associated with high mortality. It comes in the septic shock category. So let's see the continuum of sepsis. I know that more of the definition are obsolete now, but the patient, your surgical patient, post of day or two, and he's having fever, tachycardia, tachypnea, his leukocyte counts are high, or more than 10% beds and peripheral blood film and WBC counts are low. So patient is you come to think about that patient is generating some systemic inflammatory response syndrome, and in presence of an infection, it becomes an sepsis. That was the old teaching. Now, the modern definition of the sepsis has incorporated, it is grossly an umbrella term, and it is more, we can say it is not precise, but it is more like philosophical term. Severe sepsis and septic shock, that severe sepsis terminology has been obsolete now, because every sepsis is severe sepsis. Either you have septic shock or you have sepsis. Now, the septic shock is microcirculatory dysfunction associated with high risk of mortality. Or in objective parameters, we can say that patient with sepsis, with hypoperfusion, in the terms of higher lactate, his mean arterial pressure is not maintaining despite vasopressor support. He's having prolonged capillary refill time. You can say that it is septic shock. Now, in the term of sepsis, there is life-threatening organ dysfunction, and organ dysfunction we should have some objective parameters by which we can define organ dysfunction. So this is the sequential organ failure assessment score that is consist of depending on the lung, and there are lab or clinical parameters. For brain, it is GCS, it is a clinical parameter. For the cardiovascular system, it is main arterial pressure. For liver, it is bilirubin, coagulation, platelet, lung, PF ratio. So any deviation of the SOFA point, any deterioration more than 2 SOFA point was telling you that organ is failing. Now, this was the Q SOFA score or quick SOFA score, came huge in 2018. Though the latest guidelines have recommended against to use it alone for the screening because it has shown inferior to SIRS criteria and modified early warning score. New early warning score we have seen yesterday talk. So QSOFA was designed to identify the patients who are at high risk of developing sepsis. But though it is more sensitive, but it is less specific. That's why it has taken a step back. So upon identification of a septic patient, there are certain steps you need to follow in a timely manner to improve the patient outcome. Let me give you an example. If a patient of acute anterior wall MI comes to the ER, its mortality is only 10% in a modern scenario. For septic shock, the mortality is 30%. That's how grave this medical emergency is. But obviously, the heart attack is taken a priority because of the public perception. So to change that public perception that septic shock is a medical emergency, you need to measure lactate level. If the lactate level are high, you should begin 3-step antibiotics, fluid resuscitation, and vasopressor simultaneously. And before administration antibiotics, you should obtain blood culture before administering antibiotic. That was the bundle from 2018. Now, this bundle has been criticized because of the timing of that broad spectrum antibiotic. So, what was the issue that there are diagnostic uncertainties. So, you are if you are if you are thinking that this patient is in septic shock, he is very critically ill, you right away administer the antibiotics. But if there are alternate diagnosis is available, and that's why the timing of antibiotic has been dissected in the 1 hour or 3 hours, we will see later. So upon recognition, you should initiate the treatment early. The septic shock is an emergency. You should begin treatment and resuscitation immediately. And mind you, the all 3 steps, you can see that all 3 infusion pumps are running simultaneously, the fluid, antibiotic, and vasopressors. So, for sepsis-induced hypoperfusion and septic shock, give at least 30 ml per kg IV crystalloid. Begin immediately to be given in 3 hours and do various measures to guide resuscitation. And what are the various methods for assessing circulation is you can use improvement in the mental status, you can use capillary refill time, you can use stroke volume or pulse pressure variation if the arterial line is in place. And you can see that if there is high variation in high stroke volume variation, they are more likely to increase their cardiac output after fluid administration. Now, the concern about antibiotic timing was that if by chance there is any alternate diagnosis, so they have sort of dissected it. If your patient is very sick, he is in shock, you should administer antimicrobial immediately upon the recognition of sepsis within 1 hour. Now, if my patient is relatively stable and I think maybe some alternate diagnosis there, if I think that the sepsis is definite or probable, I will start antibiotic immediately. But if by chance, if there in the history or clinical examination, or we can wait for like 2 3 hours to know the any infectious or non-infectious cause of acute illness, then we can wait up to 3 hours in the initiation of antibiotic. And still, and if the concern infectious disease concern persists, then we can continue the antibiotic. Now, the choice of antibiotic will remain on the PK/PD principle. So, what are the pharmacokinetics and what are the pharmacodynamics of that antibiotic that will be uh, uh, deciding factor for your antibiotic administration. So, if you are considering aminoglycoside and if you are giving 500 milligram too early, that is the common practice in the post-op surgical notes, it won't help. So, whenever you are infusing any antibiotic, it achieves certain peak concentration, and with the metabolism and volume of distribution and pharmacodynamics, it gets what's out from the system. Now, there are certain antibiotics which have an antibiotic killing property at the Cmax, like aminoglycoside. So, if your prescription is saying amikacin 500 BD, it won't help. 750 milligram OD is better than 500 BD. Similarly, in beta lactams like cephalosporin or penicillin or meropenem, the antibiotic killing property is time dependent. So the more infusion, more time, prolonged time of antibiotic is getting in the blood circulation, it will kill the bacteria more effectively. Most of the time, as we see that in surgical ICU, the meropenem was is being given in 30 minutes bolus dose in 100 ml saline. It's like sending your army for 1 hour and giving them rest for next 2 hours. So this is the practice that can be changed, particularly in case of any carbapenem administration. Now, vasoactive management, mind you that all three-step fluid, antibiotics, and vasopressors are uh, uh, coming in picture simultaneously. So, use of norepinephrine as a first line of vasopressor. In patient with sepsis and septic shock on pressure, your target should be 65 of mean arterial pressure at least, and after initial stabilization it should be individualized. So if a patient with chronic hypertension, the target of map of 65 will not be sufficient. You need to put mean arterial pressure at which his normal physiology would have worked. Now, in consideration, this is the weak recommendation considering the invasive monitoring of the arterial blood pressure, initiating vasopressor peripherally if you cannot access the central access that has been included in the guideline. If the MAP is adequate despite low to moderate norepinephrine, you should consider adding vasopressin. And if the diastolic cardiac dysfunction with persistent hypoperfusion despite adequate volume status and blood pressure, you should consider adding dobutamine or switching to epinephrine. The most important step is infection source control. So if you identify any source of infection, in this case, or surgical site infection, or any IV device is there, that is, are you thinking that this is the possible source of infection that should be removed? You should implement the source control intervention as soon as possible, and daily assessment of de-escalation of antimicrobial treatment should be done. Now, after the fluid initiation, after antibiotic and hemodynamic stability, you need to de-escalate on the uh, fluid content. It has shown that whatever the resuscitation amount of fluid you have given, after the improvement of that patient, you need to de-escalate. So by the end of day 4 or day 5, you need to give a patient a diuretic shot to remove excess fluid from the circulation. Now, ventilatory part and the general ICU care that has been already, ventilatory part will be covered in our next class by Dr. Devin Juneja sir. And the basic program, like basic steps, nutrition, potty, CLAPSI, and a web prevention bundle has been taken care in yesterday session. So by this, I will end my slide. Thank you. Over to you, sir.
Very nice and elaborative presentation, Dr. Pramod. I must congratulate you for such a crispy presentation. And any questions in the chat box, Dr. Ravi?
No question, sir. We can
No
proceed with the
questions so
next
far.
session.
Yeah, Dr. Sashti, you are also there?
Oh, yes, sir.
So, okay. So, any questions? I think it was a very nice and elaborative presentation. I must think one thing that the SIRS or systemic inflammatory response syndrome still holds true. I think so.
Yes.
Because in many patients, what we see in acute pancreatitis or in trauma, I think SIRS has got a definite role. I think something which we discarded in the new definitions, but I think it still holds true. Okay, so I think we should move on to our next presentation.